Okay, thank you, Niels, for this introduction, and thank you, everyone, for being here and this opportunity to show you a few cases from French Guiana. First of all, a few words about this country, as I'm always asked several questions when I talk about French Guiana in international congresses. So this is a French territory located in South America. So we do have a French healthcare system and a French organization, but most of the territory is covered by a deep rainforest, just like that. And we have a very South American ecology. And regarding the populations that you may find in this territory, we have Native Americans or Amerindians. They are the first inhabitants of French Guiana. You also find Creole populations, descendants of slaves that were imported during the 18th century. And also Maroons, they are descendants from slaves that escaped from the plantations and recreated African kingdoms in the hinterlands of French Guiana. And finally, at the bottom left of the picture, you see Brazilian gold miners who work illegally in the forest to dig up some gold, and the French military who usually chase them across the forest. And these are the two populations of most of interest regarding infectious diseases. And this is like a picture of our everyday life in French Guiana and the way we do our dermatology routine care. So we often have to take plane, boats, or helicopter to reach our patients, and we perform on-field missions to go into the small settlements of the hinterlands. So I made a big effort today not to speak about leishmaniasis or leprosy. So what I propose is a few cases of tropical fungi in gold miners from French Guiana. The first one is a 17-year-old male. He is infectious diseases inpatient ward for a suspicion of tuberculosis, with a typical aspect of tuberculosis, pneumonia, fever. He has lost 20 kilos. He's HIV negative, but all TB screening come back negative. He has this small ulceration on the chin, and well, the infectious disease just called the dermatology resident to get some opinion. Now we do a simple smear and a direct examination, and you can see on this stain that we find large yeasts with small budding yeasts coming out of the larger ones, with this aspect of Mickey Mouse ears, so to speak. And this is pathognomical of paracoccidioidomycosis. It is also called South American blastomycosis in a few old articles. This fungus belongs to the genus Paracoccidioides. It is endemic of South and Central America. It is potentially lethal, and you will find it mostly in exposed professions like farmers, woodmen, or miners. Yep. Here you can see the cycle. So the fungus lives in the environment, and people working in the forest or in the agriculture will get contaminated when walking the soil, and it will be a contamination through inhalation. And then the fungus is going to spread through the lungs, possibly into all organs. Usually the presentation is chronic. Usually it's disseminated, and it really looks like tuberculosis. And actually many patients that are diagnosed with tuberculosis are actually infected with paracoccidioidomycosis. So it may affect the lung, the lymph nodes, the skin, and the mucosa, but of course the skin is the fastest and easiest way to confirm the diagnosis. You can have many different cutaneous presentation. There is a very wide spectrum of clinical signs that you can have on the skin or on the mucosa. It can look like leishmaniasis, like cancer, like lobomycosis. This is one of our very old pictures from my predecessor, Roger Pradino. To confirm the diagnosis, you need to do a smear and a direct examination. If you can afford it, you can try to do a culture and a PCR. And as I said, it's much easier to do it on a skin biopsy or on a skin smear than on a lymph node biopsy or a lung sample. You will get this budding yeast aspect, and the treatment relies mostly on amphotericin B and itraconazole for consolidation or for mild forms. This is another aspect. Case 2 is a Brazilian 30-year-old woman. She works as a cook on a gold mining camp, and she presents these nodular lesions, slightly itching, disseminated on 4 limbs, and this is a very chronic evolution for 3 years. She's hospitalized, but for something entirely different. Here you can see a close-up. And when we do the skin biopsy and have a direct examination, you can see hundreds of yeasts, and you can see that these yeasts on the MDG stain are gathered in a chain with double bridges. And this aspect is typical of lobomycosis, which is caused by the fungus Lacasia loboi, which has been recently rebranded as Paracoccidoides lobgeorgii. So this is actually a cousin of paracoccidoidomycosis, but it is caused by specific strains of Paracoccidoides, which you cannot grow in culture for some very genetic reasons. It was first described by George Lobo in 1931, and you will find it in all forest areas of South and Central America. It is very, very neglected, and the cycle is still poorly understood, probably linked to an aquatic feature. When you have Native American people living along a river and you move them to another area, you may observe a disappearance of lobomycosis cases. So there is probably a link with water, but it's still unclear if there is a vector or something like that. Clinically, it usually looks like a keloid scar, but you also can have atypical form with plaques or pseudotumoral forms. Usually affects the lower limbs, very often the ears, and sometimes the upper limbs. Here you have this aspect on the knees. Here's a very old case, which actually looks a bit like diffuse leishmaniasis or lepromatous leprosy. The treatment relies on 3 options: itraconazole, leprosy multi-drug therapy. It was discovered in Brazil. The authors had a few cases of people who had leprosy and lobomycosis, and when they treated leprosy, lobomycosis disappeared as well. So you may use leprosy multi-drug therapy, antifungals like itraconazole, and when it's possible, surgery is usually the best option. For example, this patient underwent this surgery in our department and is now completely healed. The third case is a 40-year-old male from Georgetown, Guyana. So this is a former British Guyana. This man is infected with HIV. He has only 1 CD4 left. He is hospitalized for general alteration, and he has these disseminated patches, which really look like a classical dermatophytosis. Here is a close-up. But when you do the skin biopsy, you actually see small yeasts positive on the Grocott stain, typical of South American histoplasmosis. So American histoplasmosis is usually an HIV opportunistic infection. It's actually the first opportunistic infection in South America. It is more frequent than tuberculosis, and for decades, there have been thousands of cases of so-called tuberculosis in South America, which actually were histoplasmosis that were misdiagnosed. It's usually is seen in very immunosuppressed patients, and the treatment relies on amphotericin B and itraconazole as a consolidation. Here is an example of a mucosal case. You can have a very wide spectrum of presentation. Like this one, small patches, brownish patches like this. There is often an association with other infections or malignant disease. For example, this is HTLV-1 lymphoma. Or here you have histoplasmosis associated with Kaposi sarcoma. This is an example of nose involvement in histoplasmosis. This is nose involvement in paracoccidoidomycosis, just to show you that all these fungi can be mistaken for one another. So the mycological diagnosis is very important. And I will finish with this case. This is another Brazilian gold miner with this nose involvement, but this one is much more simple. It's just mucosal leishmaniasis. And this is natural evolution. Thank you very much.